This is our workshop on social prescribing, and before we start to talk about what social prescribing might look like or might mean for you individually or in your organisation, just want to take the opportunity to tell you a little bit about the All Ireland Institute of Hospice and Palliative Care. Now, I recognise quite a few of you, and I'm hoping that most of you do know at least something about what we do. We're a collaborative institute that works all across Ireland, and we have a wide range of partners, hospices, universities, and third sector partners as well. We're very grateful to our funders because it's through their generous support of the organisation that we're able to facilitate workshops and discussion like the one that we're having today. So just a thank you to our funders. And those of you who do know us know that at the core of what we do is collaboration and connection. And our job is about helping create an environment that is conducive to collaboration. What we try to do in conjunction with the people that we hope to have an impact on, our partners, our stakeholders, and the general wider community, is we try to identify themes that we think will have the most impact on people's lives in terms of specialist palliative care. And then we try to bring our expertise, the expertise of our members and others together to see, well, is this an issue that we can do something about? And if so, what might that look like? And today is a really good example of that. So we want to whet your appetite, we hope, in relation to social prescribing, and then facilitate and support you to go off either as individual organisations or as collectives, collaboratives, to do something about this. So just a brief overview of the workshop. I am going to give you a very, and I mean very brief introduction to social prescribing, and our two speakers are going to go into it in a little bit more depth. I'm going to refer to some of the delivery that's happening across Ireland at the moment. We'll have our two speakers, David and Mary, and then we'll have a panel discussion and hopefully some sense of what might come next. Today is not going to answer all of your questions. It's really more about creating some interest in social prescribing as a concept and a model. We hope that some of you will go off and do something with this information. And whilst the concept has been around for quite a while, we do find that it's often not very well understood, or the information that we would hope that would be out there about social prescribing isn't always as evident as we might think it is. I am a programme manager for education and practice within the Institute, but my real passion for social prescribing comes from my work that I did prior to the Institute. And as part of that, I was co-chair of the Northern Ireland Regional Social Prescribing Board, and I did that up until summer of this year. And the reason why I'm not part of that anymore, I will explain to you a little bit further on in my presentation. But I've been a long time supporter of social prescribing in Northern Ireland, certainly. So that's also part of the reason why I was really keen that we would look at what might the links between social prescribing and palliative care be. Because I think you'll see as we progress through this session, there are many linkages, connections, and places of overlap between what you already do instinctively in your roles within palliative care and what social prescribing models do as well. And I'm sure our speakers will go into that in a little bit more detail. I'm kind of have a love-hate relationship with definitions. I think they can be useful, but only as a guide to what something is or might be. And as I said, social prescribing as a concept and a model has been around for quite some time, and yet we still really struggle to come up with a definition that everybody can get on board with and that everybody can agree with. It's really, really challenging to adequately define its scope and breadth, and maybe that's not a bad thing. But I'm going to show you two definitions here, and we'll have a look at them and see, well, what are the commonalities between both? So this is the UK Social Prescribing Network definition of social prescribing. And there is an emphasis on this, on the role of primary care in social prescribing. So social prescribing is, I suppose, a mechanism, or one of the mechanisms to help reduce reliance on medication for issues that quite often have social roots and social causes. So if you think about it, loneliness can present as depression and be treated as with antidepressants. Type 2 diabetes is often treated with medication as a first, I suppose, a first line of action. But what social prescribing models and other models will often find is that there are other ways to treat the early onset of type 2 diabetes that are much more social in their nature, such as, increase in exercise through participation in walking groups and other types of group exercise. Anxiety is often treated with medication. Weight issues can be treated with medication, and yet social prescribing can be a great alternative and provide alternative ways of helping people understand why those things might be an issue for them and come up with solutions to them. This definition does have some focus on the holistic nature of social prescribing, and it does also refer to linkages with the community and voluntary sector. I think I probably prefer this definition though, which is the HSE definition. And it has an emphasis more on people. It really puts people at the centre of social prescribing and their engagement in supports. A referral won't necessarily originate from a primary care professional. So lots of people who avail of social prescribing supports do that through self-referral or referral through some other type of professional. It's really important, I think, though, at this stage to say that social prescribing is not about duplicating or replacing what already happens either in primary care, secondary care, or in communities. It's very much about aligning with what is already happening and adding value to that. And I think when David talks, he might refer to some asset mapping work that he was part of and that he knows of. And really that asset mapping part of social prescribing, sorry, going to mute someone. That asset mapping part of social prescribing is a really core element of it. So hopefully our speakers will talk a little bit more about that. So the social prescribing board that I was part of commissioned a baseline report so that we would really have an understanding of what social prescribing looked like in Northern Ireland, because up to that point we really didn't have a clear understanding of all of the different models and the way in which they were funded and who was leading what bits of it. So in May 2022, this report was produced. I can't put a link to it into the chat box because it isn't anywhere online that you can go and download. But what I will do is when we post the recording of the session, I will also post a copy of the report so that you can read it, because if you're interested in this stuff, it actually does make for really good reading. And as of May 22, this was the kind of scope of social prescribing programs that we had in Northern Ireland. So we had a big program called Spring that was supported and delivered right across Northern Ireland and was funded by the National Lottery. Alongside that was the Spring Enhanced Rural Project, and that looked at social prescribing in rural geographies, and that was funded by the Department of Agriculture, Environment and Rural Affairs. We had Connected Community Care, which is a big social prescribing programme in the Belfast Trust area that was supported by Belfast Local Commissioning Group and Macmillan. With Impact Age Well, which is in Mid and East Antrim, and that works with GP practices, community pharmacies, social workers and local community and voluntary sector groups, funded by Dunhill Medical Trust and the Health and Social Care Board, and has now been mainstreamed. With the community health trainers model from the Southern Health and Social Care Trust through the Verve network, and then Caring Communities, which is in the Southeastern Health and Social Care Trust. What wasn't mentioned in the programme or in this table was a big social prescribing cross-border programme called Empower, which was funded through Interreg as one of the COT projects. And it came to an end at some stage last year. There is an evaluation report of it. If I can find it while the others are presenting, I'll put the link to it into the chat box. There's also Connect North. So if anybody's here from Northern Health and Social Care Trust, when it comes to the discussion bit, if you know anything more about this, feel free to put your hand up and tell us. But a new Health and Social Care Trust social prescribing programme called Connect North. And then Paul Barton previous colleague of mine is here today, and he will be taking up post as a social prescriber with the Southern Trust. And I know Jared Leddy from Southern Trust is here as well. So again, if you've any more information and any of that stuff that you can share with us at the end, please do. So as a concept, social prescribing is meant to help ensure that people are viewed as whole beings, not just a set of physical kind of symptoms that require treating. And it should challenge professionals to recognise that physical symptoms that are presented quite often have social causes and roots, and medical interventions might not be the only or even the most appropriate solution. Social prescribing should always have people at the centre, with health professionals, other professionals and communities kind of wrapped around them in a sort of a scaffolding support. Many lessons learned throughout the formulation of that baseline report, and lots of it won't be any kind of surprise to you. So the alignment with current definitions of social prescribing is very much influenced by referral sources and the intensity of approach. What we discovered was that there is a continuum of support that we see in social prescribing models that can go from signposting right through to much more intensive, months, maybe years worth of support to a person, and everything in between. And where the referral comes from can also really dictate the way in which the social prescribing happens. So whether it's self-referral, referral from a community organisation, or referral from a primary care professional. Holistic social prescribing seems to happen best when there are strong links to multidisciplinary teams in primary care. There's a whole range of referral criteria that can affect who avails of the support and why they avail of it, and that can be age, geography, and the type of presenting issue. There's definitely a lack of consistency in terms of the terminology and the extent of the language, or the way in which the language is understood across programs and models and projects, both for staff and people engaged in those social prescribing services. And in more integrated models, we tended to find that the money followed the person much more than other less integrated models, i.e. those that didn't have such a strong link into multidisciplinary teams or primary care. Another thing we found was a real element of success was where the social prescribing model actively invested in the community and voluntary sector that it depended on to deliver services. Hopefully that makes sense. That seems to be a bit of a defining characteristic as well. In Northern Ireland, unfortunately, the social prescribing landscape is in a bit of turmoil. So as far as I understand it, the Spring programme is no longer funded. The big lottery funding, as you will know, is only ever available for a defined period of time. And I think that there's been an issue in securing the mainstream funding that would be required to continue the rollout of that programme. To my knowledge, the other models are still in operation, but the Northern Ireland Social Prescribing Board no longer meets. And part of the reason for that was that key personnel involved in that were redeployed during the most recent restructuring of health and social care in Northern Ireland. That's not to say that it won't be resumed at some point in the future, but for now, social prescribing doesn't have the same strategic focus maybe that it had previously. Within Ireland, it's a different picture. So social prescribing in the Republic of Ireland is a mainstreamed activity now, and which I think is a really positive move. So it's commissioned. There's set and dedicated funding for it. There is a social prescribing framework, and I'll put the link to that into the chat box. Again, there's probably some of you on the call that know a lot more about this than I do. These are some slides I'm showing you that Orla Walsh, who has HSE responsibility for social prescribing, she had shared them with me. She had hoped to be with us today, but just wasn't available, unfortunately. So that this slide kind of gives a very high level overview of what the social prescribing model looks like in the Republic of Ireland. So it identifies that it starts with the person, the service user. Referral can come either from the person or a professional. There's that transition in both into the service and then out of the service, follow-up review, and then the reporting of any impact on the person themselves that would contribute to the overall kind of outcome summary information that's provided. So this is the part of the Healthy Communities Initiative. Implementation started in 2021, and the hope was that there'd be 47 HSE funded sites by the end of 2023. Now, to be honest, I don't know where they're at with that, but I do know that they should be there or thereabouts. There is also a new older persons community link workers, if I'm using the right terminology, I'm not sure, but a new focus on older people within communities that will certainly link to and add value to what's happening with social prescribing. Just want to very quickly show you this, and I know David's going to talk to us about the All Ireland Social Prescribing Network. It's a really good website. Again, if I can, I'll pop the link into the chat box for you. But I know quite often people will say, but how do we find out? How do we know what's happening and where? And there's an interactive map on the network's website that you can go in and see what is happening and where. And the HSE in their social prescribing framework refer to this website and to this map as a kind of a go-to resource. I'm hoping it's still up to date. And then evaluation. So this, I think, a really interesting aspect of what the HSE have done. So they've recognised that it's not just enough to invest in the delivery of services. We've really got to be able to say, and so what? So what difference is it making? And there is an outcomes framework attached to social prescribing delivery in the Republic of Ireland. There's a set of minimum outcomes related to personal wellbeing, social connectedness, an emphasis on qualitative data as well. So it's not just all about the numbers, it's also about the stories. And then, as you see, there procurement of a digital software platform to support the collection of that data. That, again, I'm not sure just where they're at with that, but it looks good in that there's a strong government commitment to this as a model. Not everybody might like this particular model of social prescribing, but at least there is something there, and there is a commitment to appropriate and robust evaluation of it. So just in summary then, before I hand over to David, there's lots of opportunities for palliative care to link into what's happening with social prescribing, and it's not about necessarily setting up your own social prescribing models. First and foremost, I think it's about finding out what's happening in your local community and what you can connect into. But really obvious links, I think, to what you're doing in-house, home-based and in the communities. I think social prescribing has an opportunity to really add value to that and complement what you do. But to go into it realistically, because like everything, it does require planning, and it requires resource, and it requires significant leadership as well. So I am going to stop talking now and stop sharing my screen. I am going to introduce our first speaker, who is Professor David Robinson. And David is a consultant geriatrician at St James's Hospital, a senior clinical lecturer at Trinity College Dublin, and he graduated from Trinity in 1996, completed his basic and specialist training in Dublin and in Queensland, Australia, and was admitted to the Specialist Register of General Medicine and Geriatric Medicine in 2010. And he is director of the Memory Clinic at St James's Hospital and co-chair of the Social Prescribing Network of Ireland. So, David, I can't see you on my screen anymore, so I'm hoping that you haven't disappeared on me.
No, I'm here.
You're there. Happy days.
Yeah, listening to you and foostering in the background. Grand.
Well, thanks, David. I'll hand over to you now.
Okay, so I shall share my screen and start this. Cool. Can you all see that? Yeah. Cool. Great. So thanks very much. I've adapted this talk from something else, so I shall try to keep to time. I've got, is it 20 minutes or thereabouts? Yeah. Cool.
Yeah.
Okay, great. So So I was quite proud of this photograph, actually. I was this walking in the IMA, the Royal Hospital, Kilmainham, in the December time, and I turned around and the sun was just framed behind the tower like that. So I just took a photo. So this is the structure of my talk, and it's mostly stories, and it'll touch on some of what you were talking about in terms of the how social prescribing has become mainstreamed in Ireland, which we're very pleased and proud of. This is my background. Why should you listen to me? I was so tempted to just come on wearing this Dalmatian costume, but I didn't. Why should you listen to me at all? Well, you mentioned I graduated from Trinity in 1996. I worked in palliative care for a year. I worked in hospice home care in Our Lady's Hospice in 2000. So I worked with Hilary Brady, Stephen Higgins, Liam O'Shearon, and Michael Carney was just leaving at that time. And palliative care was something I was very interested in on a personal level. My brother died at home with the input of a palliative care team. Our GP, Dr. Yelverton, was supported by a palliative care team, and that was in 1993. He died of leukemia, and that I could see the value of it. I don't know if there was a pump, but there was definitely morphine. It allowed him to die at home, and I could see the value of the home-based approach, the multidisciplinary approach to it as well, and the holistic approach was very valuable. I did an MD in cognition, which helped me, which is why I'm in the memory clinic, and I did a master's in healthcare ethics and law. My thesis for that was around the fair deal, as you know, the nursing home funding, and I wrote a thesis on it, and I still don't understand it. It's that complicated. So in terms of social prescribing, I don't know where I got this definition. It might be from the UK social prescribing network. I think of it as a way of demedicalizing the interaction, and this was covered already in terms of a person who might be slightly down or depressed, a person who might be isolated or overweight, goes to their GP. A person might be smoking, and they go to their GP, and the GP can prescribe an SSRI or Ozempic or some poison essentially to help address that person's medical needs. But in fact, it's the social determinants of health that account for up to 80% of health outcomes. And social prescribing is a way of demedicalizing that encounter, a way of addressing the social determinants, and a way of addressing things like social isolation, physical inactivity, mild anxiety or depression. For me, a lot of it comes back to control. And that's something I learned in the hospice about how there's very little in life that you can control. But if you can't control, if you don't have money, there's a lot of your life that you have no control over. And that leads to stress. And that leads to being overweight, to smoking, to drinking, to all those maladaptive ways of coping with lack of control in your life. And social prescribing is a means of returning that to people. And I'll talk about the magic sauce in a bit. So this is the general model. It's a health professional. My own preference would be that it should come from a health professional. We're talking about different models of social prescribing, and I'll talk about this different. Some people are motivated enough to find out themselves what's on and what's local. You've got people joining meetups or people joining local community groups, and those aren't the people that we want. I mean, if people walk off the street into a social prescribing project, those people are already motivated. I think part of the value and strength of the social prescribing model is that it's a health professional who's tuned into the social determinants of health, who thinks, hang on, this person needs the attention, this person needs to be connected to their community, and it's those vulnerable people. There's two places that everybody goes to in a local village or community. One is Tesco's and the other is their GP. Friends, I've worked as locum GP, I've sat in GP practices. People come into their GPs for everything. I've one encounter where a person came in wondering, should they buy new shoes? I mean, that's the type of encounter you get in general practice. And those people don't need to see a doctor. They need to be linked into their community. So you've got a health professional who can refer to a link worker, and the link worker is the magic sauce. They demedicalize it. They switch on the kettle and they ask the person, what is it that used to fire you up? What used to get you excited or involved? And then they take up to 6 visits. The average number of visits to the link worker is about 6 to connect, to find out what it is they're interested in, find out what it is in the community that they might be interested in, and they co-create the prescription. So even the word social prescribing, we've stuck with it, but there's a lot of problems with it. It's paternalistic, the idea that the link worker is prescribing something for the participant. That's not the case at all. And the link worker is finding out what is the participant interested in, and the link worker is then presenting them with a menu of available options. They connect them in the community, and then crucially and critically, which is quite unusual in the health service, well, for doctors anyway, the link worker will then contact the person again a few weeks later and find out how they're getting on. Did they link in with the service? I know in Donegal, one of the pilot projects, or father projects in the country, things like driving lessons were one of the things that they would get people, because they were isolated. They might organize a taxi to bring the person to their first visit in part of the group activity, or they might even drive them there themselves. So there's a pragmatism, there's a flexibility, and there's a thinking outside the box. So they're also described as the people on the bridge. The link workers are people who connect different sectors. That was a real challenge for when it came to funding. When we're talking to the HSE, and they were literally saying, which box does this belong to? Which sector is it? The hospital was really enthusiastic about our project and said, this is great, but why should we fund it? It belongs to the community. And then the HSE would look at the Jameses and say, well, why should we fund this? We're already giving you hundreds of millions a year to run your project. So that was a real challenge. So in terms of, but I think the box that it ended up in was health and well-being, and it's a good way to think about it. I mean, it should apply to everybody. Firstly, the health and well-being, but then also can apply to a particular demographic. It could be people over 65, it could be people under 18, it could be people in prisons. These are all subspecialisms within social prescribing. Or it could be somebody with a chronic disease, or it could be somebody with cancer, living with cancer, either towards the end of their lives, or a cancer survivor. I know there's a lot of interest in the idea of cancer survivorship and social prescribing in that field. If you've had cancer, you've been taken out of your social networks and your work networks for a number of years while you're being treated. Your body may have changed a lot, and then reintegrating into your previous activities could be a challenge. And there's a role for social prescribing there. So this was mentioned already. The idea of different conditions, health behaviors, and then relevant assets. And diabetes was mentioned as diabetes is one of the examples that's always used. You can, for a person with diabetes, they can be referred to podiatry, optometry, all these local assets in the community. And I wouldn't underestimate how much help a person might need in supporting, in supporting and empowering them to connect to these things. So when I think of the levels of advice, I mean, we love wagging our finger at people. We tell them to just lose weight and exercise more. But then you can go a little bit further, and we've got a tool that we haven't used in our practice in a widespread way, but we've got a digital tool which can be used to enhance signposting, where you look at a map and you say, well, how about going to this podiatrist? But then the top tier would be the link worker, not yet to be replaced with artificial intelligence, but somebody that can actually sit down with the person and go through things. An example, which a link worker wasn't involved, but Fiona Mulcahy, our HIV consultant who's recently retired, she mentioned there was a person with HIV who was chaotic, missing his appointments, losing his meds on the bus, and those meds cost like up to 2,000 a month. His viral load was all over the place, just not being treated properly. His life was chaotic. And then he joined an acting class, and suddenly he had a purpose, and he had a schedule and a timetable to his week. So that became important, and his viral load improved. It became undetectable. And that's entirely due to, nothing due to the doctors or the medication, but entirely due to the social milieu in which the person finds themselves. So these are more examples. You can, men's sheds is a cliche, but it's very powerful. My uncle, his wife died of cancer as well, and he was socially isolated, joined men's sheds, and started going on bus tours around the country, took up art. He's actually really talented portrait artist, which surprised all of us. But there's real power in these things. Increasing activity, falls and balance classes, Tai Chi, referral to exercise programs. When I first started attending lectures and stories about social prescribing, I thought, this is geriatric medicine. This is what we do, and we refer people to these things. And then I also had to think about what's the difference between a social worker and a social prescriber or link worker. And I think social workers tend to deal with people who are at risk, or people who are where there may be safeguarding issues, linking people in with statutory agencies. Social prescribing and link workers are more about health and well-being, so that they may have to deal with safeguarding issues. They may have to deal with people vulnerable or people at risk, but there's less of that. It's more about health and well-being in general. There is an evidence base behind it. This is the Irish evidence. The Donegal Social Prescribing Project was not the first in the country, it was the second. The first one was in Mayo, but this one was, Anne Sheridan was involved in this one. It was funded by the National Office for Suicide Prevention, I think, originally. And it showed that GP attendance is reduced, outpatient attendance is reduced, and there were benefits on a number of subjective measures of well-being and also the hospital anxiety and depression scale. There's evidence from the UK as well. These are all before and after. There's been no randomized control trial done as yet, to my knowledge. Susan Smith and Bridget Kiley in Ireland tried to set up a randomized control trial here, but little thing called the COVID pandemic interfered with that. So these are before and after, but it's consistent. 20% reduction in attendances at outpatients or even emergency departments. Some of those could be frequent attenders or hyper frequent attenders. If you take those people off the books, well then, you know, the general average attendance will go down. In terms of LAMP, Cicero, that's my back garden in the countryside. So there's the LAMP story. When we started, the purpose of LAMP was to integrate the hospital more with the community. We've two remits in St. James's. Our ethos is that we treat everybody. We treat the people that nobody else wants to treat. Our national remit, with national expertise in MaxFax, burns, hematology, and HIV. But we have a local remit as well, which is looking after the 250,000 people in our catchment, about 13% of whom are over the age of 65. There's a huge amount of resources out in the community, but people don't know where to find them. This is a quote taken from a study done in the BMJ looking at social prescribing. Organizations come and go. The advantage of having a link worker is that they have really good knowledge. And one of the first steps in any social prescribing project is you have to pick up the phone and you have to walk out the door and you have to start making connections with the community to find out what's going on there. In terms of a web-based index, we went to Chicago, where on the University of Chicago created an urban healthy living project. It's on the south side of Chicago, which is 90% African American. The Obamas were behind it, and they wanted to set up a community-based directory of services. It was American, so it was all about technology and it was all about money. But what they did was they got local youth and unemployed people to go out and physically map and create a street census online of every single business and business asset and health asset in their catchment. And they put it into a directory and they associated then with various health conditions. So what they created was, they called it Healthy RX. If you rocked up to an emergency department or an outpatient, you had your address, you had your list of medical conditions on the computerized system, and then this system would spew out a list of all the relevant assets within a kilometre or 2 kilometres of where you lived. And they administered something like 70,000 of these over the course of a couple of years. I don't know the value of actually just giving somebody a printed list. The idea of the link work, you know, the person has to be motivated to go and look at those things. The link worker is a better approach, of course. We replicated that in Dublin, where we got 18 transition year students involved in an 8-week community mapping exercise. It turns out that was that was a hell of a lot of work in terms of, I mean, there are sex shops in Dublin 8. There were boudoirs and pubs and everything, and having to chase after the students and not let them wander into those places was great fun. They didn't collect really good data, but it was a great exercise in terms of knitting together the community. We took down geocoded location, type of activity, contact details, and opening hours. So very specific. So not just, you know, there's a family resource center at the back, but if you ring this number, then, you know, Mary on the other end of the phone, she conducts dance classes for older people on Tuesday afternoon between 2 and 5, that kind of really specific information. Keeping it updated, of course, is a challenge. In terms of the assets, so that's the, anyone who hasn't been to the War Memorial Gardens in Island Bridge, you should go, they're absolutely beautiful. So in terms of what we collected data. That's our catchment area there. Collected data on 6,000 assets over 700 kilometres of street, covering a population of 200,000. There are about 600 of the assets in that 6,000 which are directly health and social care related. And as part of that, when Michelle Obama came to Ireland, we were invited to a private showing of Riverdance in the Gaieties. That was nice. What we did with that information, we put it into an online database that's searchable. and that's still a work in progress, to be honest. From what might interest you guys, and I'm sorry I wasn't able to get more detail on this because my computer at work collapsed. But we actually looked at cancer-specific assets as well, and there's a surprisingly huge amount. I mean, there were makeup artists with specific skills in people with cancer, people wig shops. There's one in Harold's Cross, I guess, just down from the hospice. So there was and then there was a lot of other generic stuff that's specifically associated for people living with cancer or ending their lives with it. Just I thought out of interest, compared to Chicago, they covered 600,000 people. We covered 200,000. They collected 18,000 assets. We had 6,500. So about right. They had 45 staff in their data lab. We had nobody, and their project cost over 3 million, and we did it for €70,000. Their website is closed. You have to subscribe to get their information. Now, our website was free. It's down at the moment, but it was free and open to anybody. So. I don't know how sustained or sustainable their project is. So in terms of the prescription engine, that's closed, so I can't talk about that before. I like this again, my dog Tegan, if you drink a bottle of wine before walking your dog, it's like you're trying to solve a crime together. I don't know if you've ever chased a dog in that way. So we have an online database covering St. James's catchment. It's designed for use at point of care. Updating it has been a challenge. We got some funding from the National Lottery to go in and update it. Our next plan is to roll it out in our outpatients and see is it a useful tool at point of care. And yeah, I describe it as enhanced signposting using a digital tool. You can't break it, and that's the website, but for the moment it's closed. So social prescribing in James's Hospital, this is just the timeline. I mean, we were banging our heads against the wall for years trying to get the HSE to fund our project. And the learning for me was to go over the HSE altogether. We went, I went to London, visited the University of Westminster in London, where Michael Dixon and Marie Polly were co-chairs of the England Social Prescribing Network. Michael Dixon is Prince or King Charles' personal physician, and he's all behind this in the UK or in England and Wales. We bypassed the HSE, and with the help of Senator Maura Devine, we presented to the Dáil. They have an audio-visual room there where you can present. No TDs attended in person, but about 6 TDs sent their teams. And that's really, I think, that's what did it. After that presentation, social prescribing was written into the programme for government, and then it all flowed after that. So, the learning for me was that the HSE implements policy, but they don't decide on policy, so there was no point in speaking to them, really. It was getting so. You mentioned there was 47 projects. This is out of date. I mean, we established our project in St. James's, then the COVID pandemic happened, and that interrupted things. But it's taken off now, and we're really pleased. So the framework was published. I was part of the steering group for that. Ireland is only the second country in the world where social prescribing has been mainstreamed and is funded out of general taxation. The goal, I think, is for one social prescriber per 90,000 people. Or is it per 50,000 people? I think it's per 50,000 people. So there'll be 90 in the Republic. And then, of course, in the north of Ireland, in the absence of a government, they were relying on bespoke funding for individual projects. Spring was the biggest of them. And as was mentioned before I started, Spring has just collapsed. So it's just off a Zoom call with Tony Doherty, and they're pretty despondent at the moment because there's nobody to talk to. And they said they have a bunch of people from England in at the moment, de facto running the health service in Northern Ireland. The All Ireland Social, the link is there. I put it in the chat as well. There is a map on. I won't switch over to my browser, but there is an interactive map on that website where you can look for local social prescribing. Anybody can refer. You can refer. So when I'm referring, I'd find out where the local social prescribing project is. I would refer to the link worker there, and I would mention whether the person has anxiety or social isolation or being overweight or whatever. After the COVID pandemic, a lot of people are socially isolated and need help reconnecting. So interestingly, I've got a patient with Parkinson's disease, and he was a dancer, and he went back after the COVID pandemic and discovered that he'd lost his rhythm. and you can't dance and step anymore. And I had another person, she was a daughter of a patient attending me, and she runs dance classes for older people, and she found after the pandemic they can't do the fast steps anymore. She's had to tone down what she's doing, so the steps are slower. A couple of case studies just to give you a sense of it. This is a 91-year-old male living alone, admitted to a hospital following a fall. This was during the COVID pandemic. So he was given painting. Now, some of the painting is a creative challenge to try and unlock his, you know, unlock his potential, or his I want to say his soul, but that's trying to think of a different word for it. In order to regain his confidence and get him back. He was also referred to a number of different agencies, which, you know, any health professional, traditionally a social worker, might do. 73-year-old female, yeah, this woman, she had a really hard life. Her husband was an alcoholic and was abusive. She was anxious about returning home. She was provided with a dictaphone. She was encouraged to tell her life story, and there was weekly follow-up from our link worker. Again, that was during COVID. So this was just at the start of it. We still restrict our referrals to our outpatient clinics. Many of them come from the nurses on the wards or the social workers, but the referral stream hasn't stopped. That was just in the first few weeks, and this will give you a sense of why people were referred to us. So the subject of inappropriate referrals is a huge one. A lot of people are too unwell, and that, you know, they may be too medically or psychiatrically unwell and to actually participate. I'm just going to fast forward to, and this is just updated figures from this week. We've had 418 referrals through to the program. 343 have been processed and discharged for various reasons, including death. There's 33 on the program at the moment, and 42 are on our waiting list. We have 1.5 or about 1.2 social workers, link workers at the moment, who are working, and we're pretty robust. One of the challenges, I think it was telling, the HSE published their evaluation framework before the social prescribing framework. The HSE are really strong, and I completely agree with them on this, on the need for evaluating the projects. We've been fairly robust at looking at collecting data before and after. So that was some of the challenges during COVID. Our link worker discovered that she was having to provide the service because there were no services to link people to, but that's all changed now. Digital inequality is a big thing. In order to use the Zoom or whatever, you need the skills to do it, you need the technology to do it, and you also need a decent internet connection. So again, poverty comes in there. Our whole social prescribing, you know, how do you measure outcomes? I mean, you know, you can look at the effect on the individual, you can look at the effect on the health service in terms of healthcare utilization, but what's also difficult to measure is the increased connections. I helped found the Dublin 8 social prescribing project by going into the Coombe Medical Centre and Rialto Medical Centre. I delivered services there for months, and then I introduced them to Fatima Resource, the Fatima Family Resource Centre, and that became a whole. So that it's difficult to measure that in terms of increased connectivity. We want to expand the link worker team with further funding. We really need to disseminate the data. That's something that we're really bad at doing. And I think subspecializing in social prescribing is probably the next thing. Social prescribing in people with cancer, social prescribing in people with dementia, all of that are individual or specific skills that our link workers are creating. We're just floating the idea of an academy of social prescribing. Our network is unfunded. It's an all-Ireland network like yours. It's unfunded, so I'd be interested in hearing ideas about funding. But I presume you're incorporated in some way, so we're not. So conclusions, social prescribing become more important. We need to expand the evidence base. Our services is very busy. I didn't do the humanities stuff, but I do now. So these are just some recommendations. Age Proof by Roseanne Kenny is an excellent book. About healthy and successful aging. Her enthusiasm for patients comes off the page. I don't know if you've read Michael Carney's Mortally Wounded is a very powerful book. As you know, he was a dream therapist and a psychotherapist as well as a really skilled physician. I've got another one of his books, A Place of Healing, which is far too dense. It goes into his ideas of shamanic medicine. And Emergencies, that is a real gem. It's out of print. I think there are only 10,000 done, and they asked every geriatrician in the country to submit a piece of prose and a piece of poetry that reflected the wisdom and resilience of aging. So we're all in it, including myself. I submitted Hospital by Patrick Kavanagh because he was a patient in St. James's Hospital with TB, I think, and he fell in love with it because he was so sexually frustrated. And also a piece from a book in science fiction in terms of prose. So thank you to all the people participating. This is far from all of them, and to our funders as well. So that's me. Thank you.
Thanks, David. That was great presentation, and really interesting to see kind of how long it's taken you to get to this point, and then what the plans are for the future. And thanks for putting those links into the chat box. So people, if you get an opportunity just to click on them, please do. I'm going to pass over to Professor Mary Lynch now, our second speaker. And Mary's a registered adult nurse with the Nursing and Midwifery Board of Ireland and holds a Master of Science in Sustainable Rural Development and a PhD in Health Economics, both of those from Queen's University Belfast. Really interestingly, Mary is a trained social return on investment practitioner with a specific interest in social prescribing, cost-benefit analysis and SROI research into public health policy and evidence-based practice. And she's one of the founding members of Social Value Hub, Bangor University, and a steering group member for the Wales School for Social Prescribing Research and Wales Social Prescribing Research Network. And Mary, I think you're going to bring a different but really, really interesting perspective and probably pick up on some of that conversation that we'd started around evaluation and how do you actually evidence the impact of social prescribing. So without any further ado, I'm going to hand over to you. Thanks.
Thank you for the introduction, Joanne. And ultimately, I suppose what I'm going to do today is briefly talk to you just a bit about social prescribing, but also my experience of social value and the Wales School for Social Prescribing Research, and also why social value is important, a little bit about social return on investment, some of the projects that I've worked on and some of the outputs from that, and also a little bit like what David said, the vision for the future of where social prescribing should and would be for to have a more cohesive approach to delivery of social prescribing. So what is social prescribing? As part of my involvement with the Wales School for Social Prescribing, we developed this framework around understanding about social prescribing is really about connecting citizens to the community support that's within them to really look at improving health and well-being outcomes. So that can be through visiting the GP or a self-referral. And as you can see through the picture, it also focuses specifically on what matters to that particular individual. But ultimately, it's about finding the community asset that's really pertinent for them and how that can link them to improving either physical or health and well-being. So why social prescribing? Well, it's a biosocial approach to the management of either long-term conditions, which are often forgotten. And it really is an empowering, and that's the key component. It's really about empowering the individual to promote and take ownership of their well-being and their lifestyle. So what matters conversation, and that really is about looking at what are the circumstances that prompted the person to seek the referral, and what do they actually want to achieve, and to know how to achieve it, and then look at, is there any risks associated with it, and look at what the person likes to do and how that can happen, and identify like that, are there barriers? So is it like, yes, they would like to go to the art class or get involved in a social prescribing intervention that will limit social isolation, but is the barrier the fact that they have a lack of transport to get there? So then how do we put that together? But it's all linked to that area of choice and signposting to the right community asset at the right time, and then providing ongoing support if required. So the Wales School of Social Prescribing Research actually started in 2018, and it actually evolved from £10,000 seed funding and has grown since then. So I'm a member of the steering group and the operational group, and it's a virtual all-school network on building on social prescribing research throughout Wales. We have links with NASP, which is the National Academy for Social Prescribing, which is in England, and also have links with Scotland. However, as David alluded to, there's difficulties in Scotland in taking that forward. But the aim of the Wales School for Social Prescribing Research is to build the critical capacity and evidence around social prescribing, both in Wales, and we have formed an international advisory group as well. The funding has now, some core funding we have secured from 2020, in the launching of the Wales School for Social Prescribing, was formally launched in April 2020, which was during the pandemic. And the funding is secured now through Health and Care Research Wales. We would run forums for students. We've put through a lot of PhD and master's students, but it's to deliver the outputs and the impacts on really 4 objectives. And it is about trying to influence practice, policy and education, about increasing capacity, and really about building that capacity as well as having high quality programs built around research and methodology. And as I mentioned, as a social prescribing, part of the Social Prescribing Evidence Centre, we are also looking at I lead for social value. So there is those work packages, and I would lead for work package 2, which is around social value. And we have recently, in the last year, introduced green art and blue spaces, because social prescribing now is happening much more in green and blue spaces, which actually improve physical health and well-being. And there's a great interest within that, and also about art and art-based social prescribing. So recently in Wales, the Welsh Government went out to consultation in relation to the National Framework for Social Prescribing. And this was building on the fact that there was a huge amount of social prescribing happening within Wales. However, they wanted to have a more greater visual picture of understanding what the all-Wales model for social prescribing looked like and the activities associated with that. And the task and finish group was really work on 4 deliverables, which are there on the left-hand side: the understanding about social prescribing across Wales, developing the national skills and competency framework for social prescribing workforce in Wales, the glossary of terms, which has just been published, and that is talking about the various words to make it easier for people to be able to communicate around social prescribing, and also evaluation and reporting standards for continual professional development materials in relation to social prescribing and evidence dissemination. So I'm here as a health economist with an interest in social prescribing, and the reason health economics plays a role is it provides a structured way of thinking, of weighing up the costs and benefits of using scarce health resources to meet needs. And through that, we like to see what health and social care can provide, how we should use health and core services and how those should be organised and what framework they should be, and how should individuals in society gain access to all these services. And there should be equity and equality, which are at the core of what economics is. So policy, I'm not going to bore you too much, but this has been the way that policy and social value has moved forward. And really it's from the introduction of the Social Value Act in 2012 to the devolved nations looking at how they would introduce and take account of the economic, social and environmental impact of activities and demonstration value for money, and how you capture that social element as well. And in Ireland, it is the Programme for Government. In the UK, it has been bringing together of the HMRC Treasury Health Green Book. And that was really about looking at the social cost benefit analysis and assessing the value for money based on well-being and interventions, optimizing the social, economic and environmental in terms of cost benefits and that linked to social value. And then we have in Ireland the wellbeing framework, and it's about improving wellbeing and utilising that information for public policy and wellbeing perspective to inform budgetary processes. So in economics, we would see economic evaluation methods as determinants of quality of life. So the National Institute for Health and Care Excellence recommend that you either use cost-benefit analysis or cost-utility analysis. And as I mentioned, the Treasury recognised that social cost-benefit analysis is the way to evaluate public health and wellbeing interventions. And the rationale for that is because it's a mixed method approach. And doing that, you can take account of all the various components. And social return on investment is a practical outcomes framework, and it takes account of, as I mentioned, the economic, environmental and social value of interventions, combining qualitative narratives which are captured through focus groups, engaging with stakeholders, also through interviews, as well as the quantitative questionnaire approach and financial measurements of real-world research. So to try and understand what social value it is really about the benefit to the community or to the commissioning or procurement organisation and why they purchase those services. And social value is best approached by considering what are the local needs and what are the context. And it's also around determining what kind of additional social, environmental value would best be served the needs of the local community. So why measure these? Because when you've got a programme for management, it's more effective in relation to planning and about effective evaluation. But as was mentioned earlier, outcomes are important, but how do we measure the impact of those outcomes and how are they important to those individuals? And then it's about how we can value that work and create that stronger communication and how we can look at doing that dissemination of outcomes and impact. And it's about enhancing and demonstrating that we're offering good value for money for the interventions that are hopefully long-term, sustainable and resilient. So why use social return on investment? It's about that social impact and the return that results from the investment. And social return on investment has originally started more within the third sector organisations and was slow to be taken on from the academic community. And the reason being, that's why the evidence base for social return on investment is only really evolving since about 2010. And with the introduction of the Social Value Act has made it clearer that people want to look at, from a third sector and moving more forward, how to value the use of public funds to be more clear and transparent. And it indicates the value in terms of the impact as well as the financial impact. So it's about the value creation. It's about looking at every pound that is invested and what is that social value return. So there should be a social value return for every pound invested. And that's what we will calculate through the social return on investment evaluation over the course of the delivery of an intervention through the evaluation. And the social return on investment will identify through the stakeholder engagement, what are the inputs, what are the agreed outputs and outcomes, to then demonstrate and measure the impact from both a health and well-being perspective, but also from a financial perspective. And then through the various methods that are used we would then look at, for every pound invested, this is the social value in return. So the key terms, as I've mentioned earlier, are the inputs, the outputs, the outcome, and they could be things like increased income, improved life satisfaction, improved well-being. But the outputs are really linked to the outcomes and impact, which is the estimated of what would have happened if this hadn't occurred in the first place. So there's a number of key stages, and those stages really are linked to involving stakeholders, which is key. So it's that co-design, co-produced approach, again, to then agree what is the framework. And normally we would gather data either in one time point of evaluation of an intervention, or we can do it pre and post. It's that lived experience that we're also trying to capture as well. So this is the Green Book, and it is available. I personally think it's really, really good output, and gives really, really good guidance, and gives a lot of organisations the backup to say, well, why they would have applied a social return on investment approach. So some of the current projects I'm currently involved in, and one is about a nature-based social prescribing, and it is to improve students' social connectedness and mental health and well-being. And it's about to value the student outcomes associated with green prescribing interventions and the actual referral pathways. Now, that is happening across North Wales at the moment with Wrexham University, and it's to look at improving, it's an area of actually increased social deprivation, and how a nature-based social prescribing intervention could improve students' outcomes and maintain retention within their programs of study. I'm also involved in leading the social return on investment with a nested cost-benefit analysis within it, within the regional integrated framework in Wales. And that is the delivery of 7 models of care. And it's trying to now, with Welsh Government, to understand which of the programs that they're currently delivering and the models of care are actually the most effective and efficient, and then to streamline those down to ensure that there's long-term reliability, resilience, sustainability, and investment in programs, both for vulnerable communities and for mainstream. And then a very interesting program is actually the Body Hotel, and that's a dance movement therapy. And the social return and evaluation of that is actually for NHS staff who have been suffering from burnout and need to improve their health and well-being. And this program is being delivered over an 8-week program. Staff have been able to attend, and the purpose of the evaluation, which we did in a one-time after they completed the program, is to measure their monetary and social value generated from the actual program and look at the value that they place on it. And it's hoping that the evaluation will demonstrate that the benefit of the program, both from a health and well-being perspective, is very important, but also the investment will actually demonstrate that it is contributing to staff's well-being, which will lead to decreased levels of sickness within work, but also retaining of staff. And this is particularly relevant post-COVID. So just some of the outputs that we've had recently, and it's really been around looking at the Open Doors to the Outdoors program was run in North Wales, and it was about getting people who had mental health conditions or who were vulnerable members of the community out into improving their social connectedness and their well-being. And that program actually was fantastic. There was a man who was homeless and now is giving back because he participated in the program and he improved his health and well-being. He started to learn new skills, now is an outdoor pursuits instructor and offers his time free to the program. and giving back. And we did a social return investment on a social prescribing intervention, which was a diabetes technician, as well as other community assets to see which was worth investing for and which had the best return. And, you know, the diabetes technician was pivotal as acting as like a social a link worker in improving the outcomes for people. And the investment there was that for every pound invested, there was up to £4.70 in return. And these are just some of the other ones which have been around social prescribing interventions, applying a co-produced approach, developing conversations, that whole area of taking the co-design, co-produced approach to understanding what's important to people in relation to social prescribing. We evaluated a really good program which was looking at an emotional mind dynamic coaching program, which was delivered throughout Wales, and we compared it both to in person as well as online. And really both, whether it was an online presence or in person, both actually had a very positive social return on investment for every pound invested, which was up to £3.50 for the online program. And then finally, myself and a colleague actually looked at something that David mentioned earlier, frequent attenders and the reduction that could happen through social prescribing activities in results to use of health resources. And within the NHS, it actually demonstrated that social prescribing activities could actually reduce costs of just over £78 per patient if they were involved in social prescribing activities. So the vision moving forward now is to create greater links now to complement actually what is happening with the All Ireland Social Prescribing Network, and to build the established social prescribing links both nationally and internationally, and knowledge transfer. And that's to create and make sure that those links with the Wales School for Social Prescribing Research and NASP in England, as well as the connections that are made in Scotland, to make sure that they continue, so that collectively we can be an additional source for dissemination of evidence in social prescribing and that transfer of knowledge. But also it's hoped that through my work now within the RCSI, that it will create collaborative opportunities for further research based on the priority needs of social prescribing in Ireland, and specifically around my area of expertise around the evaluation and dissemination of evidence, and look at the submission of collaborative research grants, applications, and generation of research income, but also to nurture high quality social prescribing real world research from an Irish context, and also the development and evaluation and translation of that social prescribing research and evaluation findings into both practice, policy, and developing educational materials, and building capacity for social prescribing through PhDs and masters by research studentships. And I've been fortunate to be able to secure some funding now, and will be looking at rolling out 4 further PhDs, which will commence in September 24, all related to social prescribing evidence building. So thank you for your time, and I hope I was able to add to the knowledge base.